Good evening, everyone. My name is Jackie, and I work in the Outreach Neighborhood Services Department here at the Ann Arbor District Library, and I just want to thank you all for joining us for this evening's program. I just want to make a couple announcements before we get started. This program is recorded, so at the end of the event, I'm going to walk around with this microphone and ask that any questions be asked into the microphone just so we can capture them on the recording. And just a second here, Chris is going to give an introduction to tonight's speaker. Thank you all for being here, and that I'll let Chris take it away. Thank you.
Thank you. Great, so thank you so much for coming out this evening. My name is Chris Monk. I'm one of the faculty members in the Department of Psychology here at the university. So tonight, I'm incredibly pleased to have Dr. Sarah Jonovich join us to discuss some of her research. Dr. Jonovich is a lecturer for and the director of clinical training for our clinical psychology graduate students here in the Department of Psychology. She completed her undergraduate degree at Syracuse University in upstate New York. She then received her PhD in clinical psychology from the University of Toledo, and following that, she was a postdoctoral fellow at the University of Rochester Medical Center. She joined us at Michigan in 2014, so it will be almost 10 years, as we were talking about. Dr. Jonovich's areas of focus are cognitive behavioral therapy, research methods in clinical psychology, and pediatric and health psychology. Dr. Jonovich has received support twice from the Lecturers Professional Development Fund here at the university, as well as the Rita P. Underberg PhD Award for Excellence in Faculty Teaching in Clinical Psychology from the University of Rochester. Dr. Jonovich's talk is particularly timely. I'm really excited to hear more about the work. The title is, as you can see, Adolescent Mental Health Crisis, Helping After the Pandemic. Here is Dr. Sarah Jonovich.
Hi, thank you everyone for coming out tonight, and I'm excited to speak with you all about adolescent mental health. I'll just dive right in. So if you've followed some of the headlines, you've likely heard about this adolescent mental health crisis that's been going on. Kids' mental health is in crisis, right? Here's what psychologists are doing. Life or death, the mental health crisis among U.S. teens. The pandemic youth mental health toll, unprecedented, data show. Right? Teen mental health is in crisis. What can parents do? Truth about teens, social media, and the mental health crisis. So these headlines have kind of been all over recently. And in February, the Center for Disease Control and Prevention released data showing that teen females in the U.S. were engulfed in what they called this wave of sadness and violence. So the numbers were really upsetting and surprising when they came out at the time. Nearly 1 in 3 teen females had seriously considered suicide. 57% of teen females said they felt persistently sad or hopeless, and 18% had experienced sexual violence in the prior year. The report also found extremely high levels of distress among sexual minority teens. More than 1 in 5 of them had attempted suicide the prior year, and more than half had reported poor mental health overall. So today we're going to dig into these numbers in a little bit more detail, kind of figure out what's going on behind this mental health crisis that's been happening. You know, are we just seeing the effects of the pandemic, or is there really something else going on here? There's a lot of questions about social media and the contribution that that plays right now. You know, and also why are females suffering so much more right now than males are? And we'll also turn to look at what parents, communities, schools can do to help support our youth and really help them cope most effectively with what's going on right now. Just to give an overview of what I'll talk about, I'm going to dive into the results from the Center for Disease Control, this youth risk survey that came out in February that's prompted a lot of these headlines. We'll look at some of the numbers that are coming out from there. We'll talk about contributing factors, so what's going on with the environment, biologically, social contributing factors. Then I'll dive into some of these strategies again for parents, the schools, and the larger community, and then I'll end with some resources and save time for questions at the end as well. Okay, so let's start first of all with these rates of mental health. When we look at the U.S. Department of Health and Human Services, they estimate that about 21 million adolescents have met criteria for a mental health disorder at some point in their lives. That's 49.5, almost 50% of all adolescents are meeting criteria. And this isn't just the occasional sadness or anxiety. This is meeting criteria for a disorder at this time where it's causing significant impairment. Diving into these numbers a little bit more, when we look at anxiety, that's probably the highest contributor right now, a lifetime prevalence of anxiety disorder among adolescents, again, ages 13 to 18. Overall, about 32%, but again, higher for females with 38% compared to males at 26%. Examples of anxiety disorders would be generalized anxiety disorder, maybe post-traumatic stress disorder, social anxiety, obsessive-compulsive disorder. Those are the things that are encompassed in anxiety. And this is just, again, diagnosed. This doesn't account for the typical ups and downs and anxieties that most people feel. When we look at depression, about 5 million adolescents had at least one major depressive episode in 2021. Again, higher for females, so 29% for females as opposed to 12% for males, so more than double. And when we look at ADHD, the lifetime prevalence for ADHD is about 9%, 3 times as many males, 13% versus females. ADHD was really the diagnosis we heard a lot about in the 90s, early 2000s, but we can see that these numbers are much smaller now compared to what's happening with anxiety and depression for our adolescents. Looking at this U.S. risk behavior survey. This is the study that came out from the Center for Disease Control, and this is a school-based survey that surveys about 17,000 high school students, grades 9 through 12 across the country. They had lots of different sites, and the CDC has actually been collecting this data for over 30 years. They put this report out a few months ago, and it followed trends over the last 10 years, looking at what's happening with adolescent mental health since 2011. Within the past 12 months on this national survey, we can see what students reported. 42% of high school students reported feeling sad or hopeless almost every day for 2 or more weeks, again, meeting that criteria for depression. About 22% reported seriously considering attempting suicide. 18% actually made a very specific suicidal plan about how they would attempt suicide. 10% reported an attempt for suicide in this high school sample, and just shy of 3% had a suicide attempt that resulted in treatment. And when they say this, it means that they had an injury, maybe they had a poisoning or an overdose, that they actually had to go to the hospital or seek medical and or behavioral health treatment. So some of these numbers can seem small, but when we think about a typical high school here in this area of 1,000 kids, to know that there's 30 kids at least at that school that are getting medical treatment, over 400 that are experiencing significant levels of sadness or hopelessness, and that's just one school with 1,000 kids. Diving into some of the specifics, these next couple tables that I'm going to show are from the CDC's recent report that came out, and we're going to look at some of these trends over time. This again is the percentage of high school students who endorsed these symptoms since 2011. And what we see when we look at that top one, those persistent feelings of sadness or hopelessness, that these have been trending in the negative direction, really, increase reports of sadness and hopelessness for the past 10 plus years. Okay? When we look at these other questions too about suicide attempts or suicide plans, these have also been trending in the wrong direction. The only one that's remained somewhat steady has been this resulted in an injury, around 3% of students. But again, that really hasn't been a change in the last, so we haven't improved in making any progress in this. When we look at some of these persistent feelings of sadness or hopelessness, this breaks it down by demographic characteristic. Going forward for the next few slides, I'm actually going to introduce and use the CDC's terminology with the demographic characteristics that they collected, just to kind of clarify. So the first one that's up there is sex, and the CDC asked people to identify as female or male sex, and we can see that females had one of the highest rates there, 57% reporting sadness or hopelessness. The second category here, race and ethnicity, we can see that a lot of them are pretty high, but with the highest being those multiracial students, 49%. The third category that's on here is sexual identity. So students were either asked to select either heterosexual or lesbian, gay, bisexual questioning. And just to note that this is a slightly different terminology than people may be familiar with, the LGBTQ. It's missing the T. The CDC didn't actually ask about gender identity in this, so it's just referring to sexual identity here. But we can see that that was 69% of people who identified as a sexual minority. And then the last category that the CDC uses is sex of sexual content. What this means, contacts, excuse me. And what this means is that students selected either that they had sexual contact with an opposite sex only or any same-sex contact. This was a different question than have you had sex in the last year, just to clarify. It was really asking about what is the sex of the person that you've had sexual contact with, okay? And as we can see from these trends, really, again, the female students, the sexual minority students, and those with same-sex partners were more likely than their peers to experience these feelings of sadness or hopelessness. When we look at some of these trends over time, again, over this 10-year period, we see that this has gotten persistently worse for both females and males, but the numbers have really exponentially grown for females. So from 36 to 57% in the last 10 years. And for males, it's been a slight increase from 21% to 29%, but both are really experiencing significant increases. When we look at the 10-year trend for race and ethnicity, for those who experience those persistent feelings of sadness and hopelessness, again, these numbers have really significantly increased, but decreased in terms of their reported symptoms. That's really been difficult across all ethnic groups, but what we see here is that it's worse, again, for those multiracial, and the Hispanic were the two. Missing from here are actually the categories of Island Pacific, Hawaiian, or a Native Alaskan, and those didn't actually have enough statistical power because there was a small sample size for those. So just to note that those are missing for certain years, and so they weren't able to show this data. When we look at the sexual minority groups, they actually reported those who had same-sex partners had 78% that were reporting, again, those feelings of sadness or hopelessness. Again, 10-year trends are missing because they had years where they didn't have enough data to report the 10-year trends on these. So I've included these in little numbers here. Okay, when we look at the numbers here about those high school students who seriously considered attempting suicide, here we have it, the 10-year trends by sex again. We can see that this is significantly increased for both females and males, with females up to 30% reporting seriously considering attempting suicide in the past year. When we look at this same question for race and ethnicity, we see that these numbers have also increased. Asian students were actually the least likely out of all the other racial and ethnic groups to seriously consider attempting suicide, but the rates really did increase for all groups again. And those sexual minority, the LGBTQ question, students had 45%, and the students who had same-sex partners had 58% that they were reporting seriously considering attempting suicide. Now, not all of these, the data that came out is bleak. So they actually asked students about their alcohol, drug use, and substance use is something in adolescence that is greatly associated with sexual risk behaviors, experiencing violence, poor mental health, and suicidality. So they follow a lot of these trends as well. And so the idea is that preventing some of the substance use in people can reduce some of their risks, as well as the risk of developing substance abuse issues later on in life. So what we see when we look at the percentage of high school students who reported drinking alcohol, marijuana, and other drugs, we see that in a positive way that a lot of these are trending in the right direction. So those numbers have gone down in the last 10 years from 39% of high school students drinking to 23%. That's really great to see. And so, you know, this looks promising, like we are doing a better job in some ways of addressing some of these problematic behaviors. So let's look at alcohol for some of the other sex and racial or ethnic differences. Here we have the 10-year trends by sex. So we see that for females, it's gone down pretty significantly, as well as males. So both have kind of shown this reduced alcohol use over the last 30 days. And when we look at this by race and ethnicity, we see the same trends of them going down and improving. And this was true across all racial and ethnic groups in the United States in the last 10 years, with Black and Asian students being the least likely to drink alcohol over the last 30 days, and white students being the most likely. However, like those other trends, when we do look at those LGBTQ questioning students, those students with same-sex partners, they did have a much higher percentage. So this 46% was those who reported same-sex partners. Something else that I think has been talked about a lot in the media recently was looking at vaping in adolescents. So this actually, they only had data for the last 6 years, but they looked at vaping. So female students were more likely than male students to currently use vaping products. And it's kind of an interesting trend that we see an improvement in 2017, then we see it worsening again in 2019, improving again in 2021, but overall these trends are still kind of going in the wrong direction. When we look at this overall by race and ethnicity for vaping, we see that white students are much more likely than Asian and Black students to currently use vape products. And we see the lowest group that's on there is Asian students. And so a lot of these have trended. When they average it out over time, it's pretty consistent. There's promise that it's getting better, but we're still not quite sure how this is going to pan out going forward. However, some of the research has actually shown that they think 3 things have really helped with this significant decline in the last 2 years. One of these being public media health campaigns. So maybe people have seen some of these ads or public health campaigns about the risk of vaping and why it's dangerous. They kind of target it to adolescents, and it's been really helpful, they think, is one factor. Another thing is that there have been significant price increases as well. So it's less affordable and people are less likely to use it if the prices goes up. And then the third thing has been sales restrictions. So they've been restricting the access laws that have been in place to limit the sales to adolescents. And they really reduced as well a lot of the flavored things that were drawing younger users. Some people might remember some of the legislation that was passed around Juul and limiting those flavored vaping products. So it is fairly impressive to see this change in 2 years. We hope that these trends will continue as they continue to get more data in this area. Oh, and I forgot there was 44%, so those were with the same-sex partners that reported vaping. Okay, so overall, when we think about improving adolescent health, there's this understanding that the environment and really impacts some of the behaviors that we're seeing. And so the Youth Risk Behavior Survey started asking about some of those variables this past year for the first time. And so these trends, again, aren't available, but they asked about some of the protective factors. The one that they thought was most important was school connectedness. So school connectedness being defined as any feeling among teens that the school cares about them, that they care about their well-being, that they care about their success. And youth who do feel connected at school are less likely to experience risk from mental health and substance abuse. So it does really serve as a protective factor. Oops. And what we see here is that only 61% of youth, of those high school students, again, from that CDC study, reported feeling this sense of connectedness. Okay? Male students actually reported a much higher percentage, 65% versus 58% for females. White and Asian students reported the highest rates of school connectedness with 65 and 67%. And the lowest, again, was those same-sex partners, 52%. So this is an area where they're really thinking some improvement can be made, and I'll talk more about that in a couple minutes. Another variable to consider as a protective factor would be parental monitoring. So what we know is that 86% of high school students reported that their parents or another adult in their family, a caregiver, knew where they were most of the time and who they were with and what they were doing. So again, looking at this as a protective factor that when we can increase parental monitoring, people are less likely to struggle with some of these other risk behaviors. Okay. Let's see here. One of the social determinants of health that this study looked at, so these are conditions in our environment that impact our health. Youth that are much more likely to have unstable housing, are much higher rates of mental health and substance use as well. And so they looked at unstable housing rates as well, and they found that 3% of high school students reported having unstable housing. What that meant was that they didn't have a regular place to sleep, that it could be that they were sleeping on friends' couches with a different relative than they usually would. They even counted things like sleeping in a shelter, sleeping in a car, sleeping at a camp or playground. All of those would be considered unstable housing. And what was also interesting from this is that when they looked at, again, some of the higher risk groups, those who reported same-sex partners had the highest rate of unstable housing at 7%. So that's more than double. Okay, so when we think about this all together, to give a little summary of all of this, we do see that these experiences were all moving in the wrong direction, and this was prior to the pandemic, right? We've heard a lot about how depression and anxiety rates have really increased, and thinking that it was worsened due to social anxiety, or social isolation, academic disruption from the pandemic, and how this is influencing, a lot of these numbers. But we see that we were actually headed in this direction even before the pandemic even struck. We see that these mental health challenges have just continued to worsen, even though, a lot of this has been identified as a concern. Specifically, I talked about the female and the LGBQ, and some racial minority students had a much higher rates of poor mental health compared to white male students for the most part. But when we look at this, we're trying to figure out what are some of the things that have been going on. There's also been talk about social media concerns, violence concerns, students who are feeling marginalized and unsupported. And while all of that we believe is contributing, that was also there prior to the pandemic as well. So we're going to think about what are some of these other contributing factors and strategies. All right, so contributing factors. Some of the environmental contributing factors that they think believed to kind of contribute to these worsening numbers. One is just some of these impacts of COVID-19. So over 250,000 children in the US lost a parent or a caregiver to COVID-19. Obviously, these children are grieving. They've had a disruption in their daily life. And so they think that this has barely been an impact for a subset of kids. And that was only parent or caregiver. There's also many more students who have had extended family, friends who have had losses. They also look at parental job loss. So 29%, almost 1 in 3 high school students reporting that a parent or a caregiver lost the job during a pandemic. Those are really high numbers. Also something they think environmentally that's going to contribute. We're going to see disruptions in routines and income. Families were really struggling during this time. The third one, environmental contributing factor, emotional and physical abuse. This was something that went up pretty exponentially when they noticed it during the pandemic. So 55% of high school students reported being emotionally abused by a parent or caregiver during the pandemic, 55%, so more than half. And 11% reported being physically abused by a caregiver. So these numbers, again, are pretty high. And what we notice is schools are a really important place for keeping kids connected, for keeping them, getting services to them, kind of monitoring these changes with teens over time. And the pandemic really disrupted all of that for teenagers. And then finally, the other environmental or contributing factors, I touched upon this a little bit with unstable housing, but some of these things that teens have experienced in terms of prolonged stress. So things such as increased in poverty, food insecurity, not having a place to live, lack of access to healthcare, education, all of these we see as things that can kind of trigger the prolonged stress that can kind of trigger the cycle of emotion regulation difficulties. And then in turn, that can kind of lead to these increases in anxiety and depression, some of these behavioral manifestations that we've seen in teenagers in recent years. Okay, let's look at some biological and social contributing factors as well. As I already talked about, the pandemic and some of these increases in mental health concerns didn't impact everybody equally. Again, those females, the LGBTQ, and those who experienced discrimination and online bullying were those groups that really reported the most difficulties with mental health since the pandemic. And what we also know from this survey, I didn't talk about it earlier, but female and sexual and gender minority students are much more likely to report higher levels of sexual violence as well compared to their male peers. And this is something they think that further contributes as well to some of the difficulties. Looking particularly at adolescent females, there was a recent study that examined some of their interpersonal stress and their social problem-solving skills. And what this study found was that females basically kind of struggle a little bit more to effectively manage and solve some of their interpersonal problems with their peers and friends, and then those students who struggle more interpersonally and solving some of these social problems that come up were the ones that were much more likely to report symptoms of depression and anxiety. So they're really seeing this tied to the ability of some teenagers to be able to effectively problem solve and kind of deal with these real life stressors that they're experiencing with friends.
May I ask a question?
Sure.
I think we need the microphone.
Yeah.
Should you just grab the microphone?
Thanks. Oh, got it.
These studies, are there efforts to kind of parse out or analyze that females are really far more likely to seek help, treatment than males, just in general, and it's been that way for years and years. I don't know how, you know, those variables could be controlled, but quite consistently during your presentation, females are, you know, more depressed, more anxious, more this, more that, and they tend to seek treatment and help.
Yeah.
Much
So,
more so than men.
yeah, and they're reporting a higher, you know, these are just reported symptoms.
Yeah.
So they are reporting much higher symptoms, yep. Yeah, and we'll get to treatment. I mean, I think, you know, treatment is available to all regardless. But yes, they're still reporting higher regardless of use of services. Yeah. Okay, so interpersonal problems and social stress. The one study looked particularly at females and saw that this was particularly relevant to them. The third thing is actually that the age of puberty has been dropping pretty consistently over the last several decades, and especially in girls. And so what we see is that this could actually lead to some difficulties processing complex feelings, knowing what to do. The regions of the brain that are responsible for kind of emotion and social behavior are actually developing much more quickly than their frontal lobes, so their ability to kind of do these complex cognitive tasks. And so they are in puberty much earlier, but they are not necessarily emotionally developing at the same rate as they are with puberty. And so what we see is now average puberty for girls is anywhere from 8 to 13 years of age, where several decades ago it was about 5 years higher. So again, maybe we're giving more complex emotions and feelings going through puberty earlier, but developmentally they're still 11, 12, 13 years old when we think about the cognitive changes that have happened to them. Okay. Going along with kind of some of these puberty and developmental changes that are natural and happening with everybody, naturally as kids age into adolescence, they're going to seek more attention and they're going to seek more approval from their peers. It's a natural drive to kind of differentiate from your family a little bit, seek some attention from your peers. And so what we notice is that though kids are starting to do this again with puberty at earlier ages, and they might not have all the skills to be able to navigate some of these complex social situations that they find themselves in. And one way that we've actually seen peers do this a little bit more is through social media. So adolescents are reaching out to peers, communicating with them. This is an outlet for them to often connect together, apart from parents in their own separate way. Yet, they might not have all the skills to be able to navigate and might be in complex situations that are really challenging to handle at younger and younger ages. We see this happening as well. And I'll talk more about those in a couple minutes. Okay. So when we look a little bit more and dive into some of the social media, we do see that there are some mixed results when we look at this connection between social media and mental health, particularly when we look at it in teenagers. It is associated with these increased risks of feeling anxious and feeling depressed. We also notice that a lot of people report physical symptoms as well, such as nausea, headache, upset stomach, right? But why are they reporting this with social media? One thing is that it is actually designed to be addictive at times. It can be very reinforcing in nature, and it really activates the brain's reward centers. It releases dopamine-like chemicals that cause us to feel good. It's often linked with kind of these pleasurable activities like food and sex and social interaction, so it keeps us coming back for more and more. And you are very intermittently reinforced. And what that means is sometimes you get something and sometimes you don't, so you're coming back, looking to see if there's more likes, looking to see if there's a new comment, looking to see how people have responded. And so it often keeps teenagers and adults, for that matter, kind of engaged and addicted to social media. People naturally kind of make those comparisons, like who saw this or what are people thinking, and then that also kind of contributes to searching back and looking for more and more social media use. Okay. There's also this well-documented and talked about fear of missing out, FOMO, where people are concerned if they're not on social media that they're going to miss out on something. Something's going to be posted, there's going to be jokes, connections, and they're going to be unaware of it. And it can also cause problems when something happens and people realize that they were left out. And so there was a party that happened and somebody posted pictures and now they're not included in that party. And so that also kind of can be a negative side effect of social media. Sleep problems. So we see this study from 2018, British study, that links social media with decreased, delayed, and disrupted sleep patterns overall. Particularly for teenagers, if they stay up later on social media and aren't shutting it down before going to bed, that often results in them getting a lot less sleep. We also see that the earlier that teenagers are using it, it has much more impactful and sometimes negative consequences, again, especially for girls. So there was a study that was done by another British journal, and they found this developmental window for girls is actually 11 to 13 years of age. Boys, it's a little older, 14 to 15. And what they saw that the more social media use they had in those kind of developmental windows, it actually predicts a decrease in life satisfaction a year later, while lower social media use actually impacted greater life satisfaction a year later. Okay, so we see that the earlier use can be much more negatively impactful. And then it also can have this distorted reality. There's all sorts of filters. There's all sorts of photoshopped images. And people are seeing these on social media, and it's a lot harder for younger people, particularly kids and adolescents, to distinguish sometimes what's real and what's not. Interesting, we give teens sometimes a bad rep for this, but adults do this as well. That there was a study that from plastic surgeons that said more and more adults were coming in asking to look like filters. So it's actually still happening to adults. But social media isn't all negative. There are some positives that come out of it. There are a lot of people who report increased connection and community from social media, particularly people who find online support groups, or people who have marginalized identities, or people who have very specific medical diagnoses, and sometimes they find communities from the larger context and really report social media can be very helpful connecting with other people. Going along with that, a lot of times people report that they get their news or announcements or stay connected to people through social media. So this is something that can also have a positive impact on adolescents and adults for that matter. And there's also some data that suggests that self-monitoring can actually help improve some of these symptoms. So there was another study that was conducted from the University of Pennsylvania, and they broke undergrad students into two random assignment groups. One, students were asked to limit social media platforms to 10 minutes per day. of their social media. So if they were using Instagram, 10 minutes, Snapchat, 10 minutes, TikTok, 10 minutes, and do that for 3 weeks. There was another group that they said, use as much social media as you usually use, but just monitor what you're doing. Just pay attention to how much you're on there and use it as you normally would. What was really interesting is that group that had it limited to 10 minutes per day, they did report significant decreases in anxiety and that fear of missing out compared to the group that used as usual. Both groups reported significant decreases in anxiety and that fear of missing out, but the group that limited their interactions to 10 minutes per day actually reported reduced feelings of loneliness and depression. So again, reduced feelings of loneliness and depression when they limited, and then improvements in anxiety and fear of missing out for all, even when they were just self-monitoring. Okay. Let's turn here to talk about some strategies. So what are we going to do? What can be helpful here, given what we know? A huge one, I think, is for parents to think about how can they help support some of the adolescents. You know, what are some strategies that parents can help put in place with their teens to think about improving social media in particular? Some of these sound pretty straightforward, but it can be a little bit more complex. So one thing is just limiting screen time. Set a limit, decide together. So many devices now have automatic timers and things that you can put in where they can shut it down at a certain time. It can be password protected. You don't have to monitor as a parent every single moment, but you can put some of these restrictions in place. And a huge recommendation that's come from psychology and from the American Academy of Pediatrics is to remove all electronics from bedrooms. So have them charged in a common area, shut them off at a certain time, and that also helps improve sleep for teenagers as well. One that I find that can be pretty humbling at times is role model. So practice what you preach, right? As parents or as adults, what are we doing with our social media that youth are learning from? If you have a rule not to have social media or phones at the table, then you also have to follow that rule as the parent. So a study from the University of Texas found that parents' use of mobile devices while they were interacting with their children led to a lot more distracted parenting. Parents also had their kids show lots more attention-seeking behaviors, trying to get parents' attention away from their phones and devices. And it also led to a lot more conflicts between caregivers and their kids. So not only is it good for us and for our kids, but we can really all reduce and practice what we preach when we think about social media use and phones. And again, this really can help improve sleep as well when we can shut down some of these devices and we can model shutting them off at a certain time. Another helpful strategy for parents is thinking about how do we educate our youth, how do we go over things such as security and privacy, knowing what some of the limits are, thinking about things and helping them think through steps before posting anything. There's this little rule, this WWGS rule, what would grandma say? So for adolescents to think, what would a teacher say if they saw this? What would a school counselor, a coach, a potential college admissions officer, what would they think if they saw these things that you posted? And to really think before posting things and make sure that you're okay with what's out there, because once it's out there, it can't come back. And then there's also these family media plans where you can set a plan together. There's a tool that I have links to here. This is a pretty helpful one that actually if you click on it, you can enter everybody's age. You can enter in different parameters. It can help you set up. It's a pretty helpful tool that clicks through all of these, and you can do it with your children to help set some of these parameters as a team. All right, some additional parental strategies. As I already talked about earlier, we see parental monitoring is just a fancy way to say parents knowing where their kids are, who they are with, and what they're doing. So we know that there's a huge protective factor that goes along with parents that have increased monitoring. So being engaged, asking them questions, following up, talking to the parents where they might be going, having that open kind of relationship where you can talk about and monitor a little bit more. And often it's not just a detrimental. Teams, and they see, why are you monitoring, or why do you want to know where I am? And the reality of it is that they know where we are as parents too, that kind of keeping this as an open family kind of approach that we use. 2, parents can help make sure that our teens get enough sleep and exercise. Another study suggested that about 70% of high schoolers don't get enough sleep. They need 8 to 10 hours. Many get way less than that. And when we're tired as adults, we also function a lot more poorly. So making sure that parents can kind of support their kids to get enough sleep and exercise. Next, engaging really in open conversations and regular check-ins. If we engage kids in conversations around their mental health, help them identify language at a very young age, it comes a lot more naturally to them as they get older. And the idea is that we want to try to keep these conversations open because they'll be more likely to come to us when difficulties arise or problems happen. Trying to find consistent times to talk to people as well as a family. If you have family dinner, great. If you're kind of on the go and you're less likely to sit down, what are some regular times you can check in? I find car rides are an excellent time to check in with kids as well because everybody's there and it's a captive audience. So finding these regular times to check in, maybe even at bedtime or in the morning. Okay. Going along with those open conversations, we want to try as much as possible to have a judgment-free home. They're going to be much more likely to come to us as adults if we are open and if we reserve judgment about things and, trying to really help encourage conversation as opposed to shut it down. Now, that doesn't mean that we don't have guidelines or we don't have expectations, but how can we do that with helping to support them and scaffold them as they're learning these skills? Paying attention to our own mental health, right? What are we modeling again for our kids? And it can be really helpful if we're struggling to get our own support as well. I often think about this in terms of the little example they give on the airline that they say if the oxygen masks fall down, you have to put your own on first before you help somebody else. And I think that this is very similar. If we're in a space where we're really struggling with some of these same things, it's a lot harder to help our kids. So it is okay, and we often talk to parents about getting your own supports and help. And then another great parent strategy is to recognize you don't have to do this alone. It is okay to get help from other adults. Reach out to other adults who know your child well, teachers, counselors, coaches, instructors, people that are really going to be able to help and support you, and you don't have to do it alone. You don't have to worry alone. Two more. So as we think about another parent strategy, watch for any of these warning signs. I kind of think about these as red flags. So when you see some of these big emotional change in teenagers, excessive sadness, crying that seems more than usual for them, increased feelings and frustration or anger or irritability, those can also be signs of depression as well. We really want to look for some of those signs and try to catch them early. We also want to look for any big behavioral changes that we see. So maybe loss of interest or pleasure in activities that they used to do. We see an increased use of drugs or alcohol, dropping grades, really big changes in sleep, any big changes in their behaviors or patterns that we've seen from before. If we see some big social changes as well, hanging out with a different group than they've hung out with before. They're not doing the activities that they used to do. They're less interested in things. These all go along with kind of some of these emotional and behavioral changes that I talked about, but we want to kind of see if they're losing connection with social friends and family. That's kind of a flag that comes up for us. Any big changes in their daily activity. Again, going along with the ones I already stated, but if we see big changes in their sleeping, either sleeping more or less, eating more or less than usual, a lot of those changes in their daily activities. Teens will at times express, too, these thoughts of suicide. So when we hear them, we want to take them seriously. If they're not being future-oriented or thinking down the road, that's another red flag for us. We want to kind of pay attention and get some support if we hear those things as well. And then the last thing, there's always going to be a subset of teens that really do need additional supports and services. So trying to connect teens with those services, again, either through the schools, through the community, ask your pediatrician, ask other friends or family. There's usually lots of different referrals that are out there. You're not the one that has to diagnose, evaluate, support your child on your own. Do it with a team of people who will help you. Okay, wrapping up here, we have some school strategies, just a couple of these. The big one here, again, being fostering school connection. So what we know is that when kids are connected to their schools, they're much more likely to report more positive mental health outcomes and a reduction in some of these other disruptive behaviors that we see. So schools actually, some of the research actually shows that when schools are viewed as supportive, even for those most marginalized students in the community, they see that schools are actually has a benefit for all of the student body. So sometimes people complain that there's programming that only helps a certain percentage of the kids at the school, but what we see is that it actually helps everybody when they're helping the most marginalized kids in that school. Another big one is making sure that we train school staff. They are trained in education. They're not psychologists. You know, teachers have so much on their plate, school staff, and that they need some training in this. And there are excellent programs that are out there. This Classroom Wise is it's a free online program that helps teachers get some of these resources in the classroom. It's really an excellent program that's been well reviewed, and it can be really helpful. It's based on kind of behavioral regulation strategies, mental health literacy, and it uses like a trauma-informed approach, so it's pretty cool. When we support, again, some of these broad programs, I talked about this just a moment ago, we have really great evidence-based treatments that have been used and developed and work. We just need them in the schools. If they're not there and reaching the youth, they're not going to be as effective. And there's this whole program called What Works in School from the CDC that, again, is evidence-based, has been really helpful, and when it's implemented in these schools, they see huge improvements in some of these numbers. A lot of this, too, starts with younger kids, so this curriculum is grades K through 12. Another thing that we notice, too, that can be really helpful for schools and for peers is having peer-to-peer support. Teens are much more likely to go to their peers than talk to an adult, and so helping peers feel confident about what to say and who to turn to for help. So there are some resources here with handouts about how kids can talk to friends with these concerns that come up. And then another great one too is putting policies in place that support. So before the pandemic, about 79% of high schools identified safe spaces for LGBTQ youth. About 77% had inclusivity of professional development for staff and trainings for them. And about 96%, so not even all of them, had anti-harassment policies. When we put these policies in place and we support those students, again, it benefits the whole community. And again, connecting those students who need additional supports, and schools are often a great source and a place to do this. All right, wrapping up, we have community strategies, the last area to talk about. One, just a huge thing that needs to happen, being able to expand the workforce and services. If anybody has tried to get services and gotten contacted a clinic, often you'll have months and months wait. I know because I am a provider, and we often have 3 to 6 month waits for people to get in. So there are lots of strategies on how to expand the workforce. There's peer-to-peer supports that can be really helpful as well, implementing some of these in schools. We see these other approaches that can really be helpful, but when we train people that aren't the traditional psychologists, social workers, we actually see some of these can be really effective as well. So increasing the number of people that can deliver these services. Increasing mental health services, mental health screenings. So this is something that has been pretty widely done, but isn't done everywhere. So pediatricians who are screening kids for mental health concerns at their well-visit child visits, and being able to identify some of these factors a little bit earlier. Again, as I talked about, increase those trainings for anyone working with youth. So it's not just the teachers, but it's also bus drivers who are getting these trainings. It's also coaches who are getting these trainings. Anybody that really interacts with youth, helping to increase some of their training so they feel a little bit more comfortable dealing with some of these concerns. And then the last thing too is some of these policies or greater legislation that can be helpful to support youth. There is one that just went through in July, the U.S. Senate Committee, and it's called this Kids Online Safety Act. It's something that's supported from pediatricians to psychologists. There's over 200 organizations that are supporting this literature to go through, and what it's actually doing is helping to hold some of the social media platforms accountable and having regulations put in place and partnering with parents and with teens to help put some of these things into legislation to help support them as well. think that's my last community. Wrapping up here, some resources and references. I do have some links to some things if anybody's interested, some book recommendations as well for parents working with teenagers as well. I have a list of lots of references for additional reading, and I think that's it. One last kind of plug. I didn't talk a lot about anxiety, but there is a film screening and a panel discussion that's coming up later this week. This is sponsored through Michigan Medicine, and it's at the Michigan Theater. So for anybody who's interested in more, this documentary that focuses on anxiety. And there's flyers available for anybody who's interested. All right, thank you, and I'm happy to answer any questions.
Okay, anybody have any questions? Just raise your hand, please.
I can start the ball.
I'll put these back up.
That was great. Thank you so much. I've just been thinking a lot about the decrease. I mean, it's just phenomenal, like going back a generation, the decrease in risk-taking behavior that you were talking about, and then this more recent increase in anxiety and depression over the last, I think you're talking about like 10, 12 years. And is there any thought, or do you have any thoughts about whether they're related, and if so, how they might be or may not be related?
Yeah, you know, there's not really a lot that kind of examines that. There's lots of other risk behaviors that were talked about. There are, unfortunately, some of these increases in sexual violence and some of these other risk behaviors. The only one, though, that had a lot of positive trends was this alcohol and drug use. There were increases in some of the other risk behaviors, so they still see them really being associated with some of these more mental health concerns that have been happening, the increased rates. However, they think that really some of this media campaign, attention brought to it, school programming, some of these suggestions that they're saying to put in place for mental health has been helpful for the decrease in alcohol use and in vaping. So they're hopeful that some of those strategies will also be helpful for adolescents. Yeah.
I would say this to support your observation about wait times and lack of availability. It's striking.
Mm-hmm.
And I say this being a clinical psychologist in private practice, and some of the anecdotal and empirical comments from colleagues and so on. I hear various presentations, and someone was working at CPH and asked two of their, I don't know, I think colleagues to put together a referral list.
Mm-hmm.
Because they didn't know who to refer to, everyone was
Yeah.
busy. So these two people got to 50 people and couldn't bottom, I mean, there was nobody available after 50. And it's true for inpatient, regardless of age. When I was trying to get someone hospitalized, and at the university, this was probably the peak of COVID.
Yeah.
And they had two people working full-time. They called them bed finders. And it was 150-mile radius, call every facility you possibly can.
Yeah.
And still didn't find anybody. Not to mention outpatient work with 3 months, 6 months, so on. I don't know what the answer is, but it's kind of heartbreaking that people wanted to
Want to get
someone.
connected, and
Yeah.
there's a 3-month or 6-month wait if they can even get in. Yeah. And I think sometimes too those do go quicker. They often say that just because they can't predict. So at our clinic we've often had up to a 6-month wait, but we try to get people in as quickly as possible. One way that I know, at least like our local school district, they have online services, and so they can get consultations for some students quicker and get them assessed. It's like a telehealth that's available for all students in our school district 7th to 12th grade. And so I think that they're trying some of these more telemedicine approaches or shorter term approaches to at least help get people connected before they can kind of get into longer term care, if that's helpful. So I think that there are some creative ways that people are working around that. There's also some studies about kind of one session, single session interventions, which has had a little bit of promise as well in terms of just getting that immediate hope and support and resource for people while they're on wait lists. Yeah.
I saw an article the other day that I've kept thinking about throughout this talk it was done in Australia, where they were looking at teaching kids DBT skills in a classroom, and it sort of backfired, and they found that the kids actually were worse off, and they think it was because, I don't know, I kind of skimmed the article, but I think what they were thinking was that the parents didn't have the skills, so they were going home, and there was kind of mismatch. The kids were trying one way, and it was family conflict and that sort of thing. But I think between that and also thinking about, on social media, it seems, at least in the social media bubbles that I'm in, it seems like people talk a lot more about mental health and what that looks like for kids. And people maybe have more literacy about that nowadays, but also it's often in a very pathologized way that, I don't know, I guess I worry about how to talk about mental health with kids and have them be aware and have them learn coping strategies without giving them a thing that they latch onto and that makes them feel worse because it's stigmatized or because, it feels like this thing that they can get diagnosed with and that it's this thing about them that's bad. That's just something I think about the balance between those a lot, and I'm wondering if you have any thoughts.
Yeah, I mean, I think the idea of introducing it in a larger classroom hopefully destigmatizes it, that everybody is learning the skill, that we can all benefit, that we all get angry, that we all need coping skills. And so I think that that's one way, hopefully the schools can do that to destigmatize some of that. In terms, I don't know that particular study, but I think what's interesting, even just from a more anecdotal perspective, is that people will say, "Oh yeah, I learned that," and I'm like, "Tell me what you learned, or how have you used it?" And they're not just a one-off skill; it is something that you have to practice, and you have to use it again, and then you have to have somebody coach you through it, and you have to have support from parents. So when they say that they learn DBT skills, I wonder how much they actually learned them and implemented them, because that's a different thing than I learned it once and it didn't work for me. We hear that a lot of time with parents. I tried to set a limit and it just didn't work. And it's sometimes it requires going back to it again and again and again. And so these are really lifelong learning skills. It's not something that somebody can teach in a classroom in 30 minutes. But I have seen some research that shows that schools that implement it in terms of the culture and from a young age and over years, they have phenomenal results where these kids really do feel that school connection and that community. And so there's been a lot of great literature in that.
So great talk, very much enjoyed it. Things that jump out at me, I'm rather alarmed at the instance of mental health concerns, symptoms, suicide attempt in young women. So as the father of a daughter, one of the things I also noticed is there seems to be, on balance, more issue with social media than benefit, and it seemed to have a dose-dependent effect, meaning if people were able to reduce or regulate their social media use, it seemed to reduce symptoms. Has there been any study about social media use by gender? Is there a chance that that could be a correlate that female young women could be using it more and that could be affecting them? And if so, what do we do about it?
Yeah, that's a good question. And there's a little bit, but they see some of the similar trends across genders as well. I don't know all of that literature very extensively, but I know that there are some that still see some of those difficulties regardless of sex. So they see it for females and males. But there is a little bit more social connection. So when we see some of the difficulties that students report with their peers, we see that it's much more likely to happen socially and through social media for females than it is for males. So males at times are more likely to engage in a physical fight, where females may be more likely to have emotional or social relationship fighting. And so they see that as kind of being connected to the social media. So maybe that fight that happens socially between two female students, now because of social media, can be broadcasted even with a larger audience. And so they see some of that online effect that happens with adolescent girls in particular. But some of the positives and negatives of social media are true regardless of the sex of the teen.
Such an interesting talk. I was curious, every time I see this data of the increase in mental health disorders, I wonder why they start at 2011, and I'm wondering what happened further back in history.
Yeah, so I can go back to some of those. They actually, this was just the 10-year report that came out this past, like here's one of them. They just looked at the 10-year trends. They do have actually 30 years of data. And so some of this stuff does go up and down. Some of these questions they didn't always ask, like the questions about vaping and alcohol use was more of a 6-year trend because they didn't ask about it before. But yes, we do have some of these, but this has been the worst levels since they've started recording. Yeah.
Thanks.
But this was just a 10-year snap. And they are collecting, they'll collect more data. They collect it every 2 years, so they will collect it this year. They're collecting, I think, in the fall, and so it'll be another year until this data comes out. So I'm interested to see, what are these changes that have happened in the last 1 to 2 years.
Are there any historical time periods where the incidence of mental health disorders went down for an extended period of time?
There has been, yes. So the suicide rates, when we look at that, we actually made huge improvements throughout the kind of late 2000s, early 2000s, kind of into the late teens. And so we saw a lot of those trends come down significantly, which was great. They also saw reductions. They ask about all sorts of things, health behaviors, other things. So we've seen decreases in pregnancies, decreases again in the drug uses, increased use in safe sex practices. So they're following lots of those things. And we have made improvements in a lot of areas.
Any other questions? No? I have one.
Sure.
I'm just curious if they studied the same drugs in the drug use questions, and if you know what those drugs were.
Yes, I do. So the illicit drugs, they define that as cocaine, inhalants, heroin, methamphetamines, hallucinogens, ecstasy. So they had all of those categories, and then I think they put them together as did they ever use any of those?
Okay.
One or more, yeah.
Thank you.
Yeah. So those were what they had as the illicit drugs. And then I think that they started using prescription opioids as well as one they started measuring. That might say on the bottom.
Yeah, it looks like 2017.
Oh, yeah. So they started asking that one. Misused prescription opioids started in 2019. They started measuring that one.